like to call this meeting to order, and if you'd all rise with me for the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Christine, would you take roll call, please?
Sure. Director Danielson?
Present.
Director Wallace?
Present.
Director Stewart?
Present.
Director Nicholson?
Present.
Director Epen?
Present.
Thank you. We have consideration of the minutes of December 10th, 15th, and 22nd of 2014. Wait a minute, let me go back a minute. Yeah. Yeah. Please.
I canceled the speaker for this evening meeting. Our education session was to be about our sexual assault response team. And our census is extremely high, and our emergency room is incredibly busy. I think all of you know that Michael Platzbacher is the head nurse in the emergency room, and his attentions are needed there just now. So I asked him to postpone this presentation until next month. And I apologize to the board, but the patient first ethic is speaking loud and clear tonight.
You have to take care of the patients.
Yes.
Thank you, thank you. Now we can go to the consideration of the minutes,
Thank
please. So I would entertain a motion, please.
So moved, Madam President.
Do I have a second? Any discussion or anything? Oh, okay, okay. Would you take roll?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Thank you.
We don't have anyone wishing to speak before the board? No oral communications?
No.
Okay, seeing no oral communications, we'll move on to, Dr. Lunny decided to take a vacation, and he asked you to fill in for him, so Dr. Achanta, would you please fill in for him, please, with the
Thank you.
report?
This month we have 2 new members joining the medical staff. Wendy Lee is an internal medicine hospitalist and is joining in the provisional active category. And Daljit Sagu is an orthopedic joint replacement surgeon who's joining as a provisional active member of the staff in private practice. We have the reappointment. The following physicians are up for reappointment. Stephanie Chang, pediatrics, in the active staff category. Joyce Cho, internal medicine, active staff category. Bogdan Eftimi, hematology oncology, active staff category. Louis Forlan, internal medicine, active staff category. Thomas Hirai, general surgery, provisional courtesy, staff category. And Lisa Lamb, family medicine, ambulatory staff category. We have 3 physicians who were transferring staff categories. Sammy Hong is a pulmonologist who is moving from active to courtesy. Jin Lin, internal medicine, is moving from active to ambulatory. And Dr. Dos Sharpel, infectious disease specialist, is moving from courtesy to active. We have 1 physician who has completed proctorship and is moving from provisional to active, and that is Dr. Patrick Duffy, oromaxillofacial surgeon. We have nobody for extension of proctorship. We have nobody for extension of provisional category. New privileges, Dr. Kirkjan, Elizabeth Kirkjan, obstetrician and gynecologist, has requested privileges for newborn circumcision, and she has met the required numbers. Resignations, we have 2 resignations. Dr. Zach Martinez, anesthesiologist, no longer practicing in the area. Dr. Nithun Verma, sleep and pediatric sleep medicine, is no longer practicing in the area as well.
Thank you. I'll ask for a motion.
Move approval.
Thank you. Do we have a second?
Second.
Christine?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Epen?
Thank you, motion passes. For the agenda, we're now on the informational section, and I'm pleased to introduce Gail Tomito, who will give us a report from what our Service League is doing.
On February 2nd, 2015, the Service League will hold its annual meeting. It will be held in Anderson Auditorium of Washington West. The new Service League Board of Directors will be elected and installed. We will also be presenting our annual donation to the hospital. We hope to match the donation of 2015, which was $55,000. Hopefully it'll be more. We will also be showing a quilt that was made and donated by Betty Jacobs, who left the area after volunteering at Washington Hospital for over 40 years. She wanted to have the quilt offered for a drawing at our 60th anniversary celebration. So we will be selling tickets and showing off the quilt at that time. We're still doing the binding on it, so it will be ready by the 2nd.
Okay.
This will be my last appearance at these meetings, as my husband has scheduled our annual vacation for the 2nd week of February, and I will be out of the country. I want to thank the Board of Directors for their support, and I have really learned a lot and enjoyed attending these meetings. I hope to have the new president attend to give our report. I also want to say that I thoroughly admire and appreciate all of your efforts to making Washington Hospital the institution that it is. I've visited other hospitals who are in dire straits and talked to their volunteers, and I'm so glad I'm part of Washington Hospital. That's it.
Thank you, Gail. That's probably the highest compliment that the hospital itself and the board could hear. But thank you, and it's been a pleasure working with you. And we know that you're not going to go anywhere except on your vacation.
Yeah.
And but we want to take a little bit of a break right now and recognize the work that Gail has done.
Oh my.
So we have this lovely bouquet of roses
Oh my
that
gosh.
we would like to present to you. So I think this is one of those photo moments, so if the board would like to join me, please, and we'll get a picture. Oh, okay.
One more. Thank you.
Okay.
Thank you very much.
Thank you for your service. Okay.
Well, my husband will be surprised.
These are the fun part.
Yeah.
This is the fun part of being on the board and being able to give presentations like that. But thank you very much for your service and the service of all of the ladies and the gentlemen who are make up the Service League. You do a wonderful job, and I know that your replacement will do an equally good job. So thank you for coming every month and being so faithful. Okay? Moving right along. Our next item is the medical staff report. Dr. Chanta.
From the medical staff, the health of the medical staff is robust. We have 554 members in the medical staff. 333 of them are active, 101 provisional active. So we have a lot of new physicians joining our force. We have 3 administrative physicians, 20 allied health professionals, 66 physicians on ambulatory staff category, 3 in the consulting capacity, and 28 who have courtesy privileges at the hospital.
So we're growing.
We are growing.
Thank you. Thank you. And thank you for standing in for Dr. Lenny.
Thank you so much.
Okay. Next on the agenda is our hospital calendar. Nancy?
First, we'll start with our video. Please, Joe.
Past health promotions and outreach events. On December 16th, the Washington Hospital management staff donated hundreds of presents, including bicycles, clothing, and toys, to Tri-City area families in need. The families were identified through One Child. One Child is a nonprofit organization dedicated to providing disadvantaged children with new clothing and school supplies. One Child's goal is to promote self-esteem in underprivileged children so they may appreciate their individual worth. On December 17th, Dr. Daniel Chertow, infectious disease specialist from the National Institutes of Health, presented to Washington Hospital physicians and staff on the ecology, epidemiology, and clinical care of Ebola patients. 80 people attended. On December 18th, first-year medical students from UCSF Medical Center provided a panel presentation for the Medical Explorers. The UCSF students provided insight and personal experiences regarding their journey to medical school. The Medical Explorers is a student organization that meets monthly to learn more about careers in the medical field. During the month of December, Lucy Hernandez, Community Outreach Coordinator, presented 8 hand hygiene classes for students at Durham Elementary, Forest Park Elementary, and Chadbourne Elementary schools, all located in Fremont. Information was provided on proper hand washing and hygiene to prevent infection and the spread of germs. 227 students participated. Upcoming health promotions and community outreach events. On Monday, January 19th, from 7 to 8:30 p.m., Dr. Victoria Leapart, gynecologist, will be presenting Restoring Balance, a 4-week stress reduction program. On Friday, January 23rd, Lincoln Elementary School in Newark will hold a health fair for students, teachers, and parents. Washington Hospital staff will host a booth to provide health information and blood pressure screenings. On Tuesday, January 27th, from 1 to 3 p.m., Dr. Eldon B. Eichbaum, neurosurgeon, will be presenting Relief for Your Neck and Back Pain. On Tuesday, February 3rd, from 6 to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jane, cardiologist, Doug Van Houten, RN, and Luann Sadweste, RN, will be presenting Living with Stroke, Future in Diagnosis and Management. On Thursday, February 5th, from 7 to 8 p.m., as part of the Diabetes Matters series, Luann Sadweste, RN, will be presenting Diabetes and Stroke. What is the connection? The Washington Hospital Healthcare Foundation Report. Washington Hospital Healthcare Foundation received 3 community gifts in December. The Leo's Club of James Logan High School made 300 holiday cards for patients at Washington Hospital. The cards were distributed to patients in the hospital during the holidays. The Leo Club is the high school affiliate of the Union City Lions Club. The Aeropostale Clothing Company donated 50 teddy bears for pediatric patients and newborns at Washington Hospital. Each year, store managers have the opportunity to choose a local nonprofit to receive the bears. For the past 4 years, Washington Hospital has been the recipient of the manager's generosity. The teachers and students of Mission San Jose Elementary School donated 30 books for children treated at Washington Hospital. The students collected donations for the books at a book fair held at the school in November 2014. The trustees of the foundation thank all of these groups for contributing gifts that benefit the patients of Washington Hospital. Washington on Wheels WOW! Mobile Health Clinic. During the month of December, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Family Resource Center, the Fremont Senior Center, the Ruggieri Senior Center in Union City, as well as Briar Elementary School. The total number of community members receiving health care at the Washington on Wheels Clinic during the month of December was 43. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was December's most viewed webpage with 13,512 views. InHealth, Channel 78. During the month of December, Washington Hospital's cable channel 78, InHealth, captured new programming, including a Washington Women's Center class, Healthy Eating During the Holidays, and 2 public service announcements on whooping cough and enterovirus D68. In addition, InHealth aired the December Board of Directors meeting. Additional events. The first baby of the new year born at Washington Hospital in Fremont was delivered by Lise Nguyen on January 1, 2015 at 12:51 a.m. At 7 pounds and 18.5 inches, baby Cara is the pride and joy of first-time parents, Mom Lise and Dad Mark. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070. And please follow us on Facebook and Twitter.
There we go. Before I get to our Employee of the Month, I wanted to make sure that the board was aware that this week we have 2,600 mental health care workers engaged in a week-long strike at Kaiser facilities statewide. Don't expect that to affect us directly. However, next week, on January 21st and 22nd, which is Wednesday and Thursday of next week, there will be a 2-day strike of Kaiser RNs. I'm going to watch very carefully. The emergency room traffic has been very heavy with the flu season nearly upon us and some people already very ill. The absence of that inpatient capacity and capacity in the emergency room is a serious issue, so we'll be following it very carefully. I also wanted to announce that the battle between Blue Shield of California and Sutter has not been resolved. The contract expired on December 31st. Blue Shield claims that the 24 hospital system that's operated by Sutter has prices that are 30% higher than other hospitals. Sutter denies that. However, Blue Shield did issue letters to 280,000 health plan members. They've been notified that they could lose network coverage with Sutter physicians and hospitals. And for us, the Sutter physicians that would be involved are Palo Alto Clinic, which is owned by Sutter. So that's also something we'll be watching pretty carefully. With that, I'd like to announce our Employee of the Month, who's Kim Moss. You have a picture up? There she is. She's our patient representative. She's clearly a very compassionate and committed and thoughtful person. She does a wonderful job in fulfilling her duties, always willing to go the extra mile and take on additional tasks. She came to Washington Hospital in 1998 and has worked in several departments in various roles, including medical imaging, patient care services, and compliance. In August of 2013, Kim joined the compliance team and took on her current role as our patient representative. And she is a very strong patient advocate who understands and exemplifies the patient-first ethic. I'm very fortunate to have her on our team. She's known for hard work and dependability. She's very much a respected member of the Washington Hospital team. She's respected not only by her peers, but managers as well. She works well with just about everybody. When she's not busy assisting patients, she enjoys reading, walking, and spending time with her husband, and she has 2 adult children. She also enjoys shopping, especially antiquing. In addition, she's active in her community, often using the gift of song as a means of outreach. I'm very pleased to announce Kim as our Employee of the Month.
Our next agenda item will be a construction report by Ed Fan. Here he comes.
Thank you, Pat. So we don't have quite yet a lot of exciting things to show you in the report, but we do have the beginning of groundbreaking. So on Monday, the parking garage got formally underway, and the trees that were back there, the asphalt, concrete, lights, all that sort of thing have been demolished. And they'll be moving forward with putting in the piers and such for the foundation. So that project is now formally underway. To remind you of the time frames, it's about a 13-month project. So we are formally underway and expect to be done by February 19th of 2016. On the Morris Hyman Critical Care Pavilion, we're still going through bidding. I thought I would share with you the latest that we've gotten in bidding, which has been positive with the exception of what we got from bids on the metal panels. The building will have the same look as the two buildings that have been recently completed, CJR and Central Plant. The exterior is metal panels. And the three bidders came in higher, almost $1 million higher than we anticipated. Rudolph and Sletton came back immediately and said they thought there were a number of things that could be done to bring this cost down, including doing away with a series of custom work on the panels to fit in to the way it was spec'd in the original drawings. So they're going back and reviewing what we can change in the drawings, and then they're going to rebid this. They've stated that they feel very confident that that will come down and will be in line with our budget. So far, as we've gone through the bidding process, with the exception of the metal panels, we've been under budget, and we believe we'll get back within budget with this change, or with the changes that they're suggesting for the metal panels. We're continuing to do bidding of the other trades according to our schedule. So through the month of January, we will have more bids come in. We anticipate having by the end of this month, we should anticipate having about 80% of the value bid, and coming forward to the board in the month of February, either the end of January or early February, with costs that we believe will be in line, and look for approval to go forward with the construction. So all things going as planned, we should get underway in February.
Very good, very good. Any questions from the board?
Okay, thank you.
Thank you, Ed. Moving right along. Next agenda item will be the quality report from the Centers for Medicare and Medicaid Services. Mary Bowen,
Thank you.
we don't really need an introduction for
Yeah.
you, do we?
Done this before. Thank you.
Thank you for coming back.
I wanted to start off before I go into my presentation with a C. diff update. Last week, we received some data from the Centers for Disease Control letting us know that our current C. diff rate has dropped significantly. And this chart displays it. In the last quarter, we ended up only having 10 cases of hospital-associated C. diff. This is a rate reduction of almost 50, a little more, than 50% for where we were this time last year at 22 cases. This is a significant reduction. It now means that we are at the benchmark with C. diff. So we are hoping to strive even further and get below that benchmark. I think it's fair to say that our cleaning efforts, our focus on hand hygiene compliance, and antimicrobial stewardship, we're starting to see some of the benefits of that. So I wanted to let you know about that.
I think we also have to thank Diane Martin, Dr. Martin, for her wonderful leadership and her determination to take this problem on and help us. I think that our partners are the medical staff in addressing this, and we were very blessed to have her. And I also appreciate the board's support in getting all of this done. Yeah. And it's been everybody helping and standing firm in the belief that we can do better.
I agree. As the chair of the C. diff task force, she was very instrumental for us getting these things done. I'm moving into my presentation. I wanted to talk a little bit tonight about Centers for Medicare and Medicaid Services, their inpatient quality reporting program. so otherwise known as CMS. They have created a inpatient quality reporting program in 2003. And really what this program was intended to do was to link quality of care to reimbursement. And in the program, they sort of reassess this every single year, and it usually typically affects your payments 2 years past the reporting period that they are looking at. If for fiscal year 2015, which we're obviously in the middle of right now, they have it set up to where if hospitals do not participate into this program, they lose a quarter of their percentage increase of their payments. So as a result, 99% of hospitals participate because it's really to your benefit. So they call it voluntary, but there's a significant price to pay if you do not participate. The stated program goals from CMS are that this is to provide patients with quality of care information so that they can make better decisions in their own health care. And it sets standards that improve patient outcomes. And also to drive healthcare improvements by using more efficient data collection. There's a second piece also to this that we feel like there is a sort of underlying agenda from CMS that focuses on using this as a means to decrease their Medicare costs and expenses and payment. As it stands now, these Medicare payments do not typically reimburse us fully for the services we provide. So this program is very important to get the highest level of compliance that we can. Otherwise, we're at risk for reducing our payments even further from Medicare. The reporting structure on this slide looks a little bit complicated, but it's actually pretty simple. We take our patient satisfaction data, we take data that we abstract from medical records, and we take data that we abstract from hospital-associated infections and claims measures that are related to our readmission reduction program and our hospital-acquired condition reduction program, and then also value-based purchasing program, which is also incentive-based payments that we get based on our quality outcomes. Our inpatient quality reporting program measurements for fiscal year 2017 are related to payments that we receive based on how we're performing today in calendar year 2015. So CMS is continually monitoring these. They monitor them throughout the year, and they're always reassessing what's the next thing they should have us measure. And as a result, they change this every single year. There's an update. We typically find out somewhere in mid-year where we think they're leaning towards, but by the end of the year, usually November, December, we have a final ruling and we know what we have to deal with in the next year. So I wanted to take some time to talk about what we're looking at for 2015 calendar year. They added 5 measurements, and they actually did remove a significant amount, 16. Some of the retained measures are things that relate to AMIs, preventing patients from developing clots, and then also making sure that all of our patients are getting their influenza vaccination. On this slide, you'll notice that SCIP-4 cardiac surgery with controlled post-operative blood glucose is listed here. Last week, CMS made an announcement that they are actually going to remove this also later on this year. And in July of 2015, we will no longer be required to submit data on this. That is atypical for them to do that at this time of year, but what happened was they had a lot of feedback about how this is no longer evidence-based practice, and so asked to have that removed, and CMS did that. So we will not be reporting that further on. Further retained measures are around stroke, perinatal care, and ED diagnosis, like how fast we move patients through the ED, how fast do we give them their medical screening exam, and how quickly do we make the decision that we want to admit them or discharge them. They look at all that data. And then we have additional requirement measures. So for this year, and again, this year that will affect payment in 2017 fiscal year, they looked at some things with readmission measures. The new one is what you see in bold, 30-day coronary artery bypass graft. So that's the CABG surgery. The readmissions within 30 days they will be looking at, and that will reduce our incentive payments further. The other ones on here that are not in bold are something we're already doing and that we've been doing for the last year or two. And down here at the bottom, you'll also notice that for the payment per episode of care, prior to this year, they were only going to give us bundle payment for heart attack, but now they've added heart failure and pneumonia. Additional requirements are centered around mortality measures with coronary artery bypass grafts. So they'll be looking at patients who have mortality within 30 days of that surgical procedure. They've left things the same as far as the hospital-associated infections go. So it's still going to be looking at surgical site infections, central line bloodstream infections, urinary tract infections when a patient has a catheter device, and as you know, C. diff and MRSA. So those listed on there will continue to be monitored. As I mentioned before, they did remove a significant amount of measures, mostly associated with acute myocardial infarction. All of the pneumonia measures that we've reported here for years will no longer be reported to CMS. Heart failure measures, same thing. That measure has been completely retired. And as I mentioned, pretty much all of Surgical Care Improvement Project has been retired. And so what CMS does is when the standard is met across the nation, and most hospitals are doing about 98, 99% compliance with this, they tend to retire the measure and replace it with a new measure. Again, this makes this a moving target. It's difficult to adjust to on an annual basis because they're changing. But again, a lot of these were removed this year. We had some pieces of the stroke measures and perinatal care measures that were removed. And sepsis management is something actually that moving forward, even though they removed the severe sepsis and sepsis shock bundle, they are currently looking at making a core measure around sepsis. So that's what we're planning to see as the next year, probably in 2016, comes out. So really our future direction with this is we'll continue to monitor this as closely as we can. We'll submit things in a timely fashion. What we would like to do internally with this is use it to our best of ability to improve quality and patient outcomes and to make sure that we meet some of our goals. And I also want to emphasize that the measures that went away that we do not longer have to report to CMS, that doesn't mean that they don't matter to us and that we're not monitoring these things. We're going to continue to monitor them internally and understand that that's still the expectation, the standard of care, but that what we are mandated to report to CMS is has changed significantly for 2015. Thank you. Any questions?
Thank you. Mary, the thought just came into my mind. Has CMS ever removed a measure and then brought it back at a later date?
That's a good question. Not to my knowledge, no.
Okay.
No, they usually, it's usually a significant process to get any of them removed. And like I said, this one that was skipped that sort of came later on after their final rule announcement, that's highly unusual. It's just that there was so much evidence around it not being maybe the best or most effective practice. They were agreed to take that off.
Okay, thank you. Any of the other board members have any questions? Okay.
Thank
you, Mary.
Thank you.
Thank you. Our next agenda item is our financial reports, presented by Chris Henry, who is our Chief Financial Officer.
Happy New Year. Tonight we'll be looking at Washington Hospital's operational and financial results for November 2014. We'll jump right in. Average daily census for the month, about 3.6 lower than we expected at 151. We had 952 admissions, pretty close to the budget of 954. Patient days for the month, however, came in 108 below budget at 4,530. Outpatient observational equivalent days for the month, been trending higher lately, 56 above the budget at 247 for the month. Our average length of stay for November came in at 4.77, just a little bit below what we had expected at 4.86. Looking at utilization, case mix index for the month, a little bit lower than we expected at 1.443. We had 149 deliveries in November against a budget of 140, so that continued to trend higher as we've seen the last several months. Surgical cases were 9 below budget for the month at 325. That includes our joint replacement cases that were right on budget at 110. Our neurosurgical cases were 10 below budget, and as Nancy had mentioned last month, we had some physician vacations and a conference involved during the month, so that volume came down. Cath lab procedures for the month likewise down about 104 at 457, and again, as Nancy mentioned, One of our high-volume physicians in the cath lab was out for a good part of the month, so that drove that volume lower. Outpatient visits were about 8.6% below budget at 6,576, and our emergency room continued to be very busy, 4,175 visits in November against a budget of 3,992. So that volume just continues to increase as we go through the year. Quick look at our cath lab distribution. Again, peripheral vascular for the month of November was the biggest piece of the pie at 44%, followed by cardiac, and then of course non-vascular and neuroradiology filling out the difference. So that volume, that shift we've been seeing was sustained in November. Looking at productivity, our productive FTEs for the month came in about 44.5 above budget at 1,169.7. We had 141 non-productive FTEs for the month, giving us total FTEs really close to budget at 1,311.4. We had budgeted for 1,310.8. Our FTEs per adjusted occupied bed, which is our productivity measure, came in just slightly below budget at 6.3. So management was doing a good job in keeping our FTEs in line. Quick look at the not a quick look, we'll walk through the financials now. First, we'll review our Governmental Accounting Standards Board presentation, and I'd just like to remind folks that aren't familiar with this, this is the format that we use for our audited financials. Total patient revenue for November came in almost $6.9 million below budget at $153,189,000. Our contractual percentage for the month came in at 77.08, and again, we continue to see that shift from the second Medi-Cal expansion, moving people out of the private pay bucket, which really gets recognized in our reserve for bad debt and charity, up to the line with the contractuals, which is our insured patients. So really that's driving that number up, and we are seeing that shift, and I believe that the governor has budgeted for additional expansion in his proposed budget, so we'll see how that rolls out during the year. So we ended the month with net operating revenue a little under $2.9 million below budget at $35,307,000. Operating expenses for the month came in about 2.7 below budget, 2.7 million below budget at 34,813,000. Big drivers there is we were a little bit over budget on our salaries and wages because we were continuing training and preparation for Ebola. The big driver here really was our provision for bad debt and charity. As I mentioned, is shifting up. So bad debt was about $1.8 million below budget at $3,415,000. We'd expected 5.187, and again, that's a reflection of seeing less private pay revenue. It's really shifting up into the contractuals with the continued Medi-Cal expansion. Benefits for the month were lower than budget by a little under $1 million. We had lower health and welfare claims and workers' comp claims in the month. And our supplies were about 4.9% below budget, really related to the volumes. So we ended November with an operating bottom line, $197,000 below the budget at $494,000. Non-operating income for the month came in at $1.173 million. That includes our property tax revenue of $185,000 that services our general obligation bond debt. And we had an unrealized gain on our investments of about $144,000. So we ended the month of November with a total bottom line about $110,000 below the budget from a GASB point of view at $1,667,000. Quick look at our Financial Accounting Standards Board presentation, and this presentation includes some adjustments that reflect the way the financial markets might look at us. Our operating bottom line stays the same at $494,000, We removed that tax revenue that supports our GO bonds and our unrealized gain on investments to come up with non-operating income from a FASB point of view of $244,000, about $58,000 below the budget, and a total bottom line of $738,000 from a FASB perspective. So are there any questions on November?
Thanks, Chris. Nancy?
I'd like to give the preliminary results for December. We saw 976 patient admissions. That resulted in an average daily census of 149. It's 94 patients lower than the budget, which had called for 1,070 admissions, and 10% below the budgeted average daily census of 165. The average daily census recorded in December of last year was 167. December's high and low census was 167 down to 120. The outpatient observation equivalent days of 273 were certainly higher than we had expected. We called for 194 in our budget. We've hired a case manager for the emergency department, which will begin to address some of the issues around patients being placed in observation. One of the other things that has begun to happen is it's not just Medicare patients that have observation requirements now associated with them. The managed care industry is following Medicare in that regard. And not all the patients are Medicare anymore. A good portion of them come from the insurance industry. Based on the average length of stay for adults and children in December, it was 4.80. That was a little bit higher than November's average length of stay at 4.77. We had anticipated 4.78, so they're all pretty much grouped together. Very small differences. The birthing center was budgeted for 138 deliveries. They saw 159. So the second month running, we're well over budget in maternity. Last year at this time, we had 136 deliveries. In surgery, we had 341 surgical cases, 4 above what we had budgeted. This includes cardiac surgical cases that were 1 below budget, neurosurgical cases that were 3 above budget, and joint replacement cases that were 4 below budget. General surgical cases were above budget by 6. Inpatient surgical activity was below budget by 4, or 1.5% variance. Outpatient surgeries were above budget by 8. 657 cases were seen at the outpatient surgery center. They had budgeted for 554. For the month of December, the total number of procedures in the cath lab, we experienced 691. We had budgeted 546. So the cath lab was booming. You compare it to last year's. In December of 2013, the cath lab volume was 540. It's a significant increase. Overall, the inpatient cath lab procedures were 64 more than we had anticipated. It's a positive variance of 26.2%. Outpatient procedures were also more than expected. We had 81 more than we expected, and that was a 26.8% positive variance. Our cardiac procedures were 46 above budget. Peripheral vascular cases were 51 above budget. Neurointerventional procedures were 2 below budget. Non-vascular interventional radiology procedures were 33 cases higher than their budget. And the ancillary procedures were 49, or 28.5% above budget. So the cath lab was a very, very busy place in December. The non-vascular interventional radiology procedures, I thought the board would appreciate an explanation of what they are. They include gastrourinary and musculoskeletal procedures. Ancillary procedures include the blood draws, moderate sedation, thrombectomies, transfusions, and other supporting procedures necessary in providing comprehensive care in the cath lab. So they are counted as procedures. Non-emergency outpatient visits for December totaled 6,998. They were 63 lower than the budget, and they were lower than the visits we experienced a year ago in December. The emergency room recorded a total of 4,469 patients, a daily average of 144. This was 165 visits above the budget and 226 visits above December a year ago. Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 3,543 patients during December, and this is 96 visits fewer than had been budgeted. Total system emergency room and clinic visits for December were 8,012, compared to a budget of 7,943. Full-time equivalents for the month of December totaled 1,310.9, including 11.9 agency personnel. This was 45.9 lower than the budget, which had called for 1,356.8 FTEs. Our productive FTEs were below budget by 54 for the month. Non-productive FTEs came in at 8.1 FTEs above budget. Productive FTEs per adjusted occupied bed were 5.4 in December, exactly the same as what we had budgeted. Total FTEs per adjusted occupied bed were 6.42, which is slightly above the budget of 6.32. Our patient mix. Our preliminary information indicates that the inpatient revenue for the month of December amounted to approximately $120.5 million, compared to the budget estimate of $130 million. Of this amount, 55.3% was Medicare, including Medicare HMO, and 19.7% was Medi-Cal. So again, we're seeing that shift from uninsured and bad debt into Medi-Cal. The thing that worries me about the state Medicaid program expansion is that the law calls for federal subsidy for 3 years, and then it goes away. And I'm not sure what will happen to the Medi-Cal beneficiaries in the state of California when that occurs. I don't know if the state will be willing to supplement the costs that have been provided for by the feds, or whether the feds will step up and issue further subsidies. It's a mystery. I guess we'll find out. So we had 130 million budgeted. We had 120.5 that we took in. 55.3% was Medicare, including Medicare HMO, and 19.7 was Medi-Cal. Moving on to revenue, came in under budget by 9.5 million, or 7.3%, but the outpatient revenue for December was above budget by 15.7%, or 6.1 million. In summary, we had 94 fewer admissions and 513 fewer inpatient days than we had budgeted. Surgical cases were above budget by 4. Cath lab procedures were above budget by 145. Outpatient visits for December were 63 below budget. ER visits were 165 higher than we had anticipated. Clinic visits for the month were below budget by 96. Total paid FTEs were below budget. FTEs per adjusted occupied bed were just slightly above. Inpatient charges for the month were below budget by 9.5 million. Outpatient charges were higher than the budget by approximately 6.1 million. So our total hospital charges for December were below the budget by 3.4 million. On December 31st, there were 174 days cash on hand. The total days revenue and accounts receivable at December 31st was 63.99. The days revenue and accounts receivable excluding Medi-Cal was 62.42. Days in accounts receivable excluding Alameda Alliance was 61.30. During the month of December, $1,274,187 of charges were approved or are pending for charity assistance.
Is there any updates on Alameda Alliance?
Not immediately.
Okay. Still the same as it was
it's-
before?
The news is not going to be good.
Okay.
We're going to be meeting with them next month.
Okay. Because
There's
I
only-
haven't heard anything either.
There's only so much that they can do with their situation.
Yeah. Okay. Thank you. Thank you, Chris. We're now to the action item section of our agenda. And we need to reappoint our Development Corporation board members. And I will consider a motion to that effect.
Madam President, I move the reappointment of Ben Saw, MD, Shirley Bushke, James Stone, Russ Blowers, and Myro Garcia to the Washington Hospital Development Corporation Board of Directors for 2015.
Second.
We have a motion and a second. Do we have any discussion from any of the board members?
These are fine people doing a great job.
This group meets quarterly, correct?
Yes.
How's their attendance?
Excuse me?
How's their attendance? Are they all
Oh,
attending?
they always all come.
Okay, good.
Excellent
Full-
attendance.
Full participation,
It
great.
would be absolutely unusual for any of them to be absent.
That's good to hear, good to know. Okay. We've had a motion and a second. Christine, would you take a roll call, please?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Thank you.
Thank you, motion passes. Glad to have these fine people continue the work that they're doing. Very good to hear. Next item is consideration of reappointment of the Citizens Bond Oversight Committee members. And I will entertain a motion for that item.
Madam President, I move for the reappointment of Albert Hueso, Jack Balch, and Kevin Holm to the Citizens Bond Oversight Committee for 2015.
Great. Do we have a second?
Second.
We have a motion and a second. Any comments from any discussion?
Again, these are great people doing volunteer work. And they show up and they keep track of, especially this group here, this is the Bond Oversight Committee that keeps track of the use of the bond funds for the construction projects. This is very important work. Very important that they are able to report to the community about the proper use of our bond funds. And this is all done as a volunteer basis.
And it's part of the district's commitment that we be on time and on budget.
They're going to have a lot more work
Yes.
in the next several years.
These are much bigger projects.
Right, and that's good to hear. And it's also good to hear when Ed gives us a report and he says, we're on budget. And particularly good when he says it's on time. So, good things to hear. We have a motion and a second. Christine, all in favor or opposed?
Wait a minute, how do we do it?
No,
Wait,
yeah, we have to do
Oh,
the
we
roll
have to do the
call.
roll call.
Yeah.
No, I just changed the wording. Wanted to see if you were awake.
Okay, you got me.
Director Danielson?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Motion passes, and we're very pleased to let these folks know that they will be appointed again, but let's not discourage them by telling them they're going to have more work to do, okay?
I think they're excited.
You think so?
Yeah.
Okay.
I talked to one the other day.
Oh, you did?
Yeah, he
Oh,
was very excited.
Good, good. All right. We're going to come to the last action item, and I'd like to take a few moments to talk about how we're going to proceed on that. The next item, the board will turn to the issue of the CEO's employment contract with the district. The board packet was posted on the district's website this past Friday, and the packet contained a cover memo from our legal counsel, Mr. Kozanchenko. The packet also included a progress report memo from our CEO and a report from the Independent Executive Healthcare Consultant, Integrated Healthcare Strategies. I now ask that Mr. Kozanchenko introduce this agenda item. Paul?
Thank you, Director Danielson. The memo that I sent to you summarizes the issues, I think, before the board tonight. I think the first 3 paragraphs I'm going to read because they really encapsulate what the board's going to be doing. And then I have a few more introductory comments. The Chief Executive Officer is the only employee of the district who is hired directly by the board. Annually, the board reviews the CEO's performance as required by the employment agreement. As part of that process, the board considers data provided by an independent healthcare compensation consultant and any and all factors that the board considers important. The board then decides whether or not base salary should be adjusted and whether or not to make an award of at-risk compensation. At this time, the board also considers whether to make any other revisions to the Chief Executive Officer's employment agreement. The district has a long-standing philosophy of wage parity for all employees, which includes the CEO. Wage parity means the CEO is not paid at the top of the scale, nor is she compensated towards the bottom. The district's compensation philosophy of marketplace parity establishes a base salary for the CEO at the 65th percentile of her peer group and total cash compensation for the CEO in the range of the 75th percentile of her peer group, with a maximum possible at-risk award of 40% of base salary. Benchmarking executive compensation based on peer group data is a standard practice for establishing reasonable compensation for executives working for nonprofits. The district's compensation philosophy not only reflects the district's long-standing philosophy of wage parity for all employees, but also acknowledges the CEO's 30-plus years of experience as a healthcare executive officer. For purposes of applying its compensation philosophy, in 2008, the board decided to adopt the blended peer group, which consisted of a blend between the adjusted national peer group and the California peer group. One of the documents in the packet is the report, you mentioned it, Director Danielson, from Integrated Health Strategies, and I want to make a couple of comments about that report. As the report indicates, Integrated Health Strategies, Healthcare Strategies, is one of the premier compensation consultants in the United States. And the reason that you get the report, and the reason we've gotten the report in past years, is because the Internal Revenue Service and its regulations provides some guidance about how to establish what's known as the rebuttable presumption of reasonableness for compensation. And among the factors in the requirements is a requirement that you receive data, comparability data, from an independent consultant. And comparability data is not just what you might hear anecdotally that someone may pay its CEO in another district. It has to be provided through an expert who can analyze the various members of the peer group and provide you with his or her opinion, in this case Integrated Healthcare Strategies, that in fact the peer data that is being provided is reflective and comparable and appropriate for you to use to establish a reasonable range of compensation. A slide or a page that I want to point out and specifically to you is on page 27. This summarizes the data that is provided by Integrated Healthcare Strategies. It's important to note that the data on that page is data reflected from a number of sources. First, Integrated Healthcare Strategies has its own proprietary database. And what that means is that over the course of providing consulting services for its clients, it receives data and is allowed to use that data in coming up with numbers. What it can't do is tell you exactly what a particular CEO is paid, but it is their data, and that's one group of data that you have on that page. In addition to that, in order to sort of test their data, they obtain data from 2 other independent sources, and those are also listed there for you to look at. And there are literally hundreds of healthcare organizations on that page. In addition to the 3 national peer groups, the Integrated Healthcare Strategies pulls out data for the California peer group, which this year consists of 22 healthcare entities. Many of those entities, I think, are going to be familiar to you on that list and are reflective of the California market. For your convenience, Integrated Healthcare Strategies pulled out just the California entities, and they appear, I think, on the last page of the report. So based on the information that you have tonight and the other factors that you want to consider, you have three tasks to consider. First, an award of at-risk compensation based on your existing compensation philosophy. Typically, the board has considered granting an award of at-risk compensation based on a number of factors reflecting CEO performance, including awards, recognitions, achievements, and financial performance. Since 2008, the board has varied its award from a low of 22.8% of base salary to a high of 40% of base salary. The second task that you have is a review of your compensation philosophy and a consideration of whether or not you want to adjust the base salary of the CEO. And the last task before you is you have typically extended the term of the contract of the CEO by 1 year as part of this annual review, and that would be the third task for you to consider tonight. And I'm available to answer any questions if you have any.
Thank you, Paul. At this time, I would like to outline how we're going to proceed, because Paul has given us our tasks. We need to do this in an organized manner. First, I will ask if any board members have any preliminary questions of Mr. Kozanchenko or the CEO or her staff. Next, I will open the public hearing so that any members of the public who wish to speak on this item can speak. I ask that you limit your comments to 3 minutes so that everyone has an equal time. After hearing from the public, I will close the public hearing and then bring the discussion back to the board for further discussion and action. During the board discussion, I will ask first to have the board discuss and consider making an award of at-risk compensation based on our existing compensation philosophy. After the discussion, I will ask for a motion. Next, I will ask the board to turn its attention as to whether or not it wants to consider making revisions to the compensation philosophy and whether the board wants to adjust the base salary. Following that discussion, I will ask for a motion. Last, I want the board to discuss and decide whether or not we wish to extend the contract by 1 year, consistent with past practices. So let's begin the procedure. Are there any preliminary questions from any of the board members?
No.
Okay, no preliminary questions. You're off the hook, Paul. No questions, okay? Is there any further questions from any members of the audience? Seeing no, pardon me.
You should open the public hearing.
Oh, I'm sorry.
Then
I need to. We're just learning how to do this properly, so please bear with us. I will open the discussion to the public hearing and ask if anyone in the public would like to speak. Seeing there's no public comment, I will close the public hearing process and bring it back to the board. Okay. At this time, consistent with what I said, I'm closing the public hearing, and I would like to first address whether we wish to award an at-risk compensation consistent with our existing compensation philosophy. And we'll begin the discussion, and if anybody has anything to comment on.
Madam President, yes, I'd like to speak about this item. The worth of a CEO is better judged in difficult financial times, in my opinion. It's often said that a rising tide lifts all boats. This is not a rising tide in healthcare business. In fact, the tide is going out in terms of money. The government has made it quite clear that they're reducing reimbursements and payments, and insurance companies are cutting payments as well. And the new policies that are coming into vogue in the world have the impact with large deductibles of delaying, in many cases, needed treatments. The impacts of all of these measures and others on healthcare in general is significant. And one needs only pick up a newspaper, turn on the TV, listen to the radio, and you can see the stress that's being placed on many hospitals across the country, and particularly in our area. We hear constantly about troubles with hospitals in neighboring areas, Valley Care and Pleasanton being taken over by Stanford, St. Rose having its difficulties in surviving, the Alameda Healthcare District, or the Alameda Healthcare, the county hospital, having a great deal of financial difficulties. And recently, the Daughters of Charity pretty much putting up, I don't know how many hospitals for sale, which is now the subject of a great amount of political debate. So it is true that the worth of the CEO is better judged in difficult financial times, and the past few years have certainly been difficult. Our revenue from 2013 to 2014 was down by nearly $20 million, with $17 million of that attributed to the Accountable Care Act and reduced Medicare payments. This is against the backdrop of our budget, our annual expenditures approaching $500 million, nearly $440 million this year. This financial situation exists in the context of many challenges. The district continues to be subject to the state unfunded seismic retrofit mandate. We have been required to spend millions of dollars upgrading our physical facilities, and we've gotten $0 from the state. The district has been required to adopt an expensive electronic medical health care record system despite this declining government reimbursement. And while the federal government has provided a small subsidy, that subsidy did not come close to covering the actual cost of the electronic health care record. This is a reality that we face, both the mandate, the electronic record. We're talking about millions and millions and millions of dollars that have to come out of the operations of the hospital or from the bond measures that we have passed to build our new facilities consistent with the mandate to seismically retrofit our campus. The CEO did not create these problems. However, like any CEO, she has to react to them. She had to make some difficult and unpopular decisions. The district clearly needed to reduce its expenses, which meant a reduction in the size of its workforce to bring it into line with reduced revenues. The CEO was able to accomplish most of this reduction through attrition and voluntary retirement, minimizing layoffs. Since July 2013, the district reduced its payroll from 1,577 full-time equivalent employees to approximately 1,311. Other initiatives to improve revenue are that, one, we secured $3 million of additional funding from Alameda County. We met deadlines for obtaining approximately $2.7 million of funding from the federal government related to the electronic health care record. And we reduced observation and short inpatient stays, improving the quality of care and reducing unreimbursed costs to the tune of $1.3 million. The CEO's, it's clear, and as we looked at the financials during this fiscal year, that over the past 5 months, earnings and revenue are up year over year. Income's up approximately $15.8 million over the same 5-month period of last year. And that is significant. The district has 174 days of cash on hand, higher than it has been over the past year. During this recent past, the district has completed the central utility plant and the Center for Joint Replacement on time and under budget. The district will be breaking ground on the brand-new critical care pavilion later this year. The electronic healthcare record was implemented. The Joint Commission, when they examined us during last calendar year, recently noted that the district's implementation of the electronic healthcare record was excellent. We cannot overstate how much of an accomplishment this is. Moving from paper to electronic records required a change to the workflow of the entire organization over the period of just a few years. The district is not a small organization, and change of this type are incredibly difficult. Yet the migration to an electronic healthcare record has been very successful and has been indicated by the Joint Commission's finding. Thank God there aren't 1,400 staff people like me here to do something electronically versus my paper-based systems. And it's a change in culture. And in order to get the entire House and district, the people that touch the records of a patient, it's a significant change in culture. And there's a lot of resistance, as anybody knows, to change one's habits is very, very difficult. And particularly when you're dealing with new jargons and a new way of doing business, change is very difficult. During last year, the Joint Commission reviewed us. We received a full 3-year Joint Commission accreditation with an acknowledgement of the district's implementation of best practices. For the benefit of the public, the Joint Commission is an accrediting body that inspects healthcare organizations throughout the country to determine whether they are meeting its high standards. The Joint Commission's findings are based on an unannounced 5-day survey, so the organization must be ready for inspection at all time. During last year, we continued to expand our partnership with the University of California, San Francisco, UCSF. We opened a special care nursery, established several new clinics, and expanded several service lines, such as cardiac surgery, making several services more available to residents and patients. We've achieved some other awards. The U.S. News and World Report rated the best hospitals in San Francisco metro region for 7 specialties, including gastroenterology and GI surgery, geriatrics, gynecology, nephrology, neurology, and neurosurgery, orthopedics, and urology. Consumer Report also indicated that Washington Hospital is the only East Bay hospital to receive the top overall excellence award in surgical site infection scores. The CEO has made a lot of tough but necessary and unpopular decisions in tough economic times. As a result, the district's financial outlook has significantly improved, and the district continues to improve on the quality of patient care it delivers. I believe that based on her performance, the CEO should receive not the maximum, but a good portion of the at-risk reward. And as I think Mr. Kozachenko indicated, over the recent past 8 or so years, the range of the incentive or at-risk compensation award has been in the range of 23 roughly to 40% roughly. As I indicated, I don't think that we should be awarding 40% at this time, but there, as I've stated, have been a lot of accomplishment in very difficult and trying times. And so given the compensation philosophy that we have, I move that the board award at-risk compensation to the CEO based on our current compensation philosophy, an amount equal to 30% of the current base salary.
Thank you, Mike. Do we have a second?
Second.
Second. Thank you. I'll now open it up for further discussion from the rest of the board. Mike has said a great deal, and I'd like to hear from the other members of the board.
Madam President, I think it's important at this point to emphasize the difficult times that all hospitals are in. When I first came on the board 12 years ago, it was a different environment, completely different environment. We didn't have the Affordable Health Care Act. We had a community where the majority or a large portion of the community was insured. We had low Medicare, Medi-Cal participation. All those things went to form a very healthy financial situation for our hospital. All that has changed, and in dramatic fashion. And particularly this last fiscal year. It's almost as though we've been caught by a wave. Mike mentioned all boats rise in a rising tide. Well, all boats crash in a tidal wave too. And that's essentially what's hit the hospital systems throughout the United States. All that being said, our CEO has made some very, very difficult decisions, and we have all participated in that in one way or another, and it's affected many lives, affected many people, and those are sad, difficult, very, very challenging things to have happen to a hospital system and to a community. I agree with what Mike has said, that even through those difficult times, our CEO has made some very difficult, good decisions that have helped bring us back, or at least steadied the boat in these difficult times. And I would, as I've already stated, I would second the motion that based on our philosophy at that time, a 30% at-risk award would be appropriate. I just want to mention one other thing. I'm particularly impressed that our hospital, in the first, I believe it's the first time that Consumer Reports has issued one of these reports, but our hospital was rated the top best hospital in the Bay Area on 7 specialty areas. I think that's a significant thing for a community hospital in this area with large institutions across the Bay and north of us, that we are rated the best hospital in the Bay Area in those 7 areas. I think that's a significant thing. So I would support the present recommendation at this point.
Thank you. Thank you. Director Nicholson, Director Epen, would either
I'll
of you
start.
like to speak? You'll start? Okay.
Sure. Madam President, I concur with Mr. Wallace's motion of a 30% at-risk award. And Mr. Wallace and Dr. Stewart have certainly outlined some of the challenges which our institution has faced in the past several years. And indeed, these are very turbulent times, and consistent with the at-sea descriptions, we are indeed in stormy waters. And not only is the weather severe and unpredictable, the waves are high, and there are many unforeseen rocks beneath the surface which tend to rise and need responding to. I would agree with what Mr. Wallace and Dr. Stewart have said about the challenges which the CEO has risen to address, which have helped keep this institution afloat and with a good trajectory. The two things which stand out in my mind are the UCSF affiliation, which provides a foundation for continued growth and excellence at this institution. The second is the implementation of the electronic medical record. Difficult as it is, and difficult as it was, and difficult as it will be as it evolves over the years, that represents critical infrastructure for coordination of care, optimizing results, and basically allowing us to analyze how we care for patients and improve the quality of care, the efficiency of care, the satisfaction of our patients, and also reducing the cost of care. So those are two very important things that have happened of late, which have been well managed by our CEO, and I appreciate the hard work. And of course, we have the Joint Commission survey, which without passing that, we would not be here. So that was passed with excellent results, and that really reflects a lot of hard work on behalf of the CEO, her executive team, and all of the staff of Washington Hospital, which has to keep things in line every day, all the time, because you never know when the inspectors are going to show up. And when they do, and when they did, we did well. And so it's for those reasons that I would agree with Mr. Wallace's motion and Dr. Stewart's second of the at-risk compensation award.
Thank you. Dr. Eben?
I also agree with Wallace's motion of a 30% at-risk compensation increase based on the board's existing compensation philosophy and the accomplishments that the CEO has achieved in the last year, which, again, I'm not going to narrate the whole thing because it's pretty much explained, especially in safety, neurosurgery, orthopedics. As you know, we are probably ranked or rated in one of the best 100 hospitals in the country, and the third best, I think, in the Bay Area. So these are all, accomplishments that has to be given credit. At the same time, hospitals, like everybody has mentioned, going through real rough times, especially district hospitals, and to survive, I think it's really a great accomplishment. So I concur with the rest of the board in giving a 30% at-risk bonus.
Thank you.
Madam President,
Yes, sir.
I think it's worth noting on Mr. Kozachenko's letter that's been posted online and visible and available to all the public. Based on our long-standing philosophy of wage parity for all employees, if we look at the IHS report from their myriad of sources that we have used as a basis for establishing our CEO's salary, base salary, and at-risk compensation. Based on that report, we have been behind in that since 2008. We have not reached the percentages that our long-standing philosophy dictate. And even today, with this at-risk compensation that we're considering, that does not bring, based on our past philosophy, that does not bring the CEO salary up to the 75th percentile, as we have previously decided. So I think it's good for the public to know that in turbulent times, I think the CEO shows real mettle in doing what needs to be done and doing it well enough that we're still doing well as a hospital. Nevertheless, we have not been able to maintain what our previous philosophy dictated. I think it's important to
That's a good point.
have that on record.
It's a very good point. I'm very thankful and impressed with the thoughtful comments that everyone has made and the effort that they've taken in doing their homework, so to speak, with this particular subject. I have just a few comments of my own. Everyone has mentioned the electronic health record, and that happens to be my profession. And I remember many years ago that the goal was to have all records into a electronic health record system by the year 2000. And we're in the beginning of a new year, which is 2015. So I think that is an indication of how challenging this process is. Dr. Nicholson, you mentioned Joint Commission. Everybody has mentioned Joint Commission and the efforts that were made and the good results of it. And there's two factors that I see in both what we have done with the electronic health record system implementation and Joint Commission is teamwork. And it's under Nancy's leadership and guidance, creating that teamwork from everybody throughout the whole healthcare system to achieving those particular goals, including the medical staff. I'm not going to forget about you, in pulling it all together, because if there wasn't teamwork, this and everybody pulling together in the same direction, none of these things would have been accomplished. It would have been total and complete chaos. So as it is, the staff, the entire hospital district staff is working together and moving forward to accomplish these goals. And I think that the outcomes that Mr. Wallace nicely outlined for us is evidence of that work. So the staff needs to be complimented, and Nancy needs to be complimented as well for creating this environment for everybody to be able to work together to create these good outcomes. I'd also like to point out that as Director Stewart has pointed out, we now have data that is more focused on what's happening here in California. And I was really impressed and excited when I saw these changes. These are our peers, and so this data is being presented to us, and it's much more realistic than we had before. It just simply was not available before. So I thank everybody for the work that they've done in researching this out. We have a motion. We've had a second. We've had discussions. So I'd like to close the discussion, and we're ready to take a vote. So Christine, would you do the roll call, please?
Dr. Danielson?
Aye.
Director Wallace?
Aye.
Dr. Stewart?
Aye.
Dr. Nicholson?
Aye.
Dr. Epen?
Aye.
Motion passes. Thank you very much. Okay, back to my agenda. Next, I want to address the issue of whether or not we want to make any changes to the compensation philosophy and consider whether we want to change the base salary of the CEO. Mr. Wallace, since you started us off before, can you continue that trend?
Okay, I want to say that I truly appreciate reviewing the annual report that was provided by our independent consultants. Apart from the considerations concerning the IRS and all of that, it's just good business practice to understand the market and pay at a market rate in order to attract and retain great executives such as Nancy. I think the report is comprehensive and provides us with data that we need in order to consider reasonable compensation. Although we decided to use the blended peer group as the benchmark for evaluating the appropriate compensation for our CEO, we have focused on that peer group every year since, but as Dr. Stewart indicated, we haven't been able to match the CEO's base salary with the increases in the blended peer group. So from my perspective, it's time that we took another look at this. I'm not in favor of adjusting the idea of the 65th and 75th percentiles. I think those are fair targets given our CEO's experience and longevity with the organization. And frankly, I think that's just a good business practice across the board anywhere. But I do think we should consider changing the peer group to something that is arguably more in tune with the California market. Taking a look at page 27 of the IHS report, and looking only at the California peer group, which is in there, the list consists of 22 peers in California. Almost all of them are nonprofits, and there are very many familiar names in there, as I'm sure you can see. I think we need to get back on track, so I'm proposing that we revise our compensation philosophy to use the California peer group as opposed to the blended peer group. But I also want to propose something else. I think the amount of the potential at-risk compensation in our compensation philosophy may have made sense at 40% when we first adopted our policy, but now should not be as high. I think that it's a little bit too much. So what I'm suggesting is that while we should match the 65th percentile of the California peer group for base salary, since that is the market, I suggest we reduce the amount of at-risk compensation potential from 40% to 20%. This is still in keeping with our philosophy of allowing for a potential total cash compensation award at the approximate range of the 75th percentile. So, consequently, I hereby move that the board amend its existing compensation philosophy by one, setting cash compensation of the CEO based on the California peer group as opposed to the blended peer group, with the base salary set at the 65th percentile of the California peer group, which, as the table in the page 27 indicates, would be $747,800. And number two, reducing the amount of potential at-risk compensation from the current 40% of base salary to 20% of base salary, and making these adjustments effective as of November 1st, 2014.
Thank you. We have a motion. Do we have a second?
Second.
Second. Thank you. I'm going to bring this back to the full board to make comments on that. Does anybody has any other thoughts on the compensation philosophy?
Madam President,
Yes.
I'd like to speak again on that. I think it's important to go back for just a minute and talk about what Mr. Kozachenko has mentioned, the IRS suggestions and responsibilities we have in properly adjusting and properly evaluating our CEO's salary. And they require us to look at a large database and try to find our best idea of a peer group that is adequate and also accurate to our particular hospital. And in the past, we've used this large national peer group and a blended peer group of California and the national group. And what's been suggested by Mr. Wallace is that we move away from that blended peer group and go to strictly a California peer group that is actually somewhat new data from IHS. And it consists of 20 California hospitals, most of which are nonprofit hospitals. I think this is a much more accurate peer group to deal with. I think it's a much more valuable tool to use in our consideration of what is fair for the CEO. So I'm very much in favor of moving to this California peer group. I believe am I right, Mr. Kozachenko, that the names of those hospitals are available to the public?
Yes, they are. They are attached to the report, and that is posted online.
Good. We have that report here also, and so it includes many of the local hospitals here: El Camino across the bay, Alameda County Medical Center. Just giving those are all available to to the public and to those who are interested in finding that out, and both Northern and Southern California hospitals. And I think it's a very comprehensive list, and it gives us a different number to deal with. And Mr. Wallace has mentioned that's our compensation philosophy of a base salary at 65% of the average of those of that California peer group would give us that number of 747.8, and I support that. I think that's a good move. I think that's a valuable way to and a very, very solid way to justify what's being offered to our CEO at this point. And I also agree that the risk compensation ought to be adjusted to 20%. If the full 20% were awarded in the next fiscal year, that would also bring our CEO's salary up to the 75th percentile of that California group. So it puts us absolutely in line with the California peer group of hospitals that are very, very similar to our hospital. Our hospital had net revenue of $457 million. The average of the California group was 449. That is extremely close. So the hospitals have the similar revenue. They're located in the same state. I think this is a valuable group to use. So I would support Mr. Wallace's motion that we change our basic philosophy to use the California peer group and base her base salary on that peer group.
Thank you.
Madam
Dr.
President. Thank you. I concur with Mr. Wallace's recommendation for the three different components of his motion. The first being adoption of the California peer group from Integrated Health Services or Integrated Healthcare Strategies California peer group to be the reference database that we use. The second component was to choose the 65th percentile level of that California peer group for establishing the base salary, and the third was going to the 20% at-risk compensation award. In healthcare, we always try to seek the best guidance, and as a board, we have struggled with this over the years and have used the data provided by Integrated Healthcare Strategies in the past, but without the local data, local being California. Now that data has become available to us, and I'd like to share with you some of the hospitals that are on this list that comprise the California peer group. Just a smattering of them. First is the Alameda County Medical Center here in San Leandro. Another is Community Hospital of the Monterey Peninsula in Monterey. Another is Eisenhower Medical Center down in Rancho Mirage. Another just across the bay is El Camino over in Mountain View. Down south, where I grew up in Orange County, is Hoag Memorial in Newport Beach, and Hollywood Presbyterian in Los Angeles. Huntington Hospital in Pasadena, where I did some of my training, and also Valley Presbyterian Hospital in Van Nuys. So these are all hospitals which comprise these are some of the hospitals which comprise the peer group. And looking at the net revenue, the size, the services that these hospitals provide, I think it represents our best available reference point to use to guide us in our decision making. I concur with the decision or the recommendation by Mr. Wallace to proceed with a 65%, 65th percentile point of that peer group for establishing the base salary. And I also agree with the 20% at-risk compensation. Because when you look at the peer groups, the base compensation, and the total compensation, it looks like the average at-risk award for the CEOs of these institutions is in that 20% range rather than the 40% range which our board had previously used in the past. So because of this, Madam President, I will support Mr. Wallace's motion.
Thank you. Dr. Eben?
Yeah. Again, I also pretty much concur with the motion of Wallace. The only thing that I wanted to highlight was, till now, like we discussed, from 2008 when IHS was hired to give us some kind of an indicator to see a peer group. We use the national peer group. One of the reasons for that was there's always a possibility that we might be hiring CEO from across the country. So that was the reason why the national peer group was selected. And like it was mentioned, we were given this, the California peer group this year. And one of the surprising things was that the California peer group numbers were actually less than the national peer group, which was kind of surprising. We would have thought that California numbers would have been higher. So in fact, the California numbers are lower than the national peer group numbers. So I concur with the motion, and that's all.
Great. Again, I want to thank everyone for their comments, and we'll bring it back to the full board for voting. We have a motion, and we have a second. So Christine, would you take roll call?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Eben?
Aye.
Motion passes. Thank you very much, gentlemen. The third item and our last item for consideration and discussion is the action item relating to the continuation of the extension of the employment, the term of agreement to 1 year.
Madam President, I hereby move that the employment agreement be extended for 1 year for a new term beginning November 1st, 2014, and ending October 31st, 2018, and the President of the Board be authorized to execute an amendment to the employment agreement consistent with the actions taken here tonight.
Thank you. Do we have a second?
Second.
We have a motion and a second. Once again, I'd like for comments from the other board members, please.
I think this is just consistent with what we've talked about tonight. We're anxious to continue and anxious to work together to further the successes and the work of Washington Hospital with Nancy Farber. I think that's a good thing to do.
Thank you. Any comments from this end of the table?
Sure. Madam President, I won't be as lengthy as I was in my prior two comments.
No problem.
No, we clearly need experienced, stable leadership of this institution to manage the stormy waters ahead, which I don't see the storm receding at any time, especially with upcoming elections in 2016. It'll be a real challenge. So I do concur with Mr. Wallace's recommendation to extend the CEO contract by 1 year.
Thank you. Dr. Eben?
I pretty much agree with what Dr. Nicholson had just mentioned. I think we need someone who knows the place and who's experienced to weather the storm. And so I pretty much concur with the motion.
One of the one of my favorite phrases right now is institutional memory, and it's a very important thing to have, and Nancy has that institutional memory to weather this storm. I'm not sure that I like Mr. Wallace's description of being in a boat. I'm trying not to get seasick right now, But it is a good description that the waters are a little bit rough, maybe more than a little bit rough, and I don't see them getting any calmer. So the institutional memory that Nancy, as our CEO, has, I think is going to be something that we really need to rely on to get us through these stormy times that we're heading down that path. So with that said, we have the motion, we have the second, we're ready for the vote. Christine, would you take the roll call, please?
Yes. Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Thank you. Motion passes. Believe, if I could get my papers in order here. And thank you, everybody, for the efforts that they have made. Thank you, Paul, for your efforts. They were a great help. We're going to adjourn to a closed session. Thank you. We are re-adjourning from closed session, and I would like to report that there was no reportable actions taken during our closed session. With that, this meeting is adjourned. Did I